Starting our session. Good evening and welcome to one and all. I am Sneha from Clearnet, the designated session assigned for the seamless experience of the session. Clearnet is very proud to be a part as a digital partner for this event organized by the Indian Society of Pediatric Nephrology. And our today's topic is Module 5, Approach to ANH. So without further delay, I would like to take this handover to this session to Dr. Jitendra sir. Over to you, sir. Kindly proceed for your talk.
Thank you, Sneha. So good evening, everyone, and thank you once again for joining us today. So today's webinar is scheduled on approach to antenatal hydronephrosis. Before we begin with the webinar, we'll have the pre-test and link for same I'll be sharing in chat box. Participants can attempt the pre-test from the chat box.
My apologies. I joined a little late. I just reached from Bombay.
Good evening, ma'am.
Good evening. Good evening.
Good evening, ma'am.
Good evening,
ma'am.
Good evening. So we have Shobha today, and who else is the other? Is Subal, right?
Yes.
Are you? Are they doing the questions now? The link has been shared.
Yes,
Yes.
ma'am.
So the topic has been introduced, Dr. Pankaj.
No,
No.
ma'am, we'll
After
do
this.
it after pre-test.
Yeah.
After
So
this, we do it.
would we follow the same? You will introduce this thing and me the speakers, or how would you want to do?
Okay, I can do this time. I can introduce the speakers and you can
No,
talk
no.
about.
I said topic. आप start करो. पहले
अच्छा,
3
मैं-
मिनट के थे अभी आप start कर लो.
ठीक है, just
And
go
I'll
on.
this thing. Yeah.
ठीक है,
So
ठीक.
just tell me, Subal, you're talking on what are the talks that who's doing the cases and this? Remind me again.
Dr. Sobha will present the first discussion part, and then I will present 2 case scenarios.
Great. So I had gone through it much earlier. What is the topic of your, how have you titled your talk? Approach to or management?
Ma'am,
Approach to antenatal hydronephrosis.
Approach.
Yes, ma'am.
Yes. And just give me your affiliation, Dr. Shobha.
ma'am, it's Professor, Department of Pediatrics and Safdarjung Hospital, sir, ma'am. VMM
Yes.
and Safdarjung Hospital.
Yes. Subal, now you're Professor
Oh, ma'am, I'm assistant professor
Associate.
and in charge of division of pediatric nephrology.
Yeah.
Cuttack.
Cuttack Medical College, no?
Yes, ma'am.
Yes. I was thinking मैं रास्ते में करना पड़ेगा, but luckily I reached. इतनी बारिश.
अच्छा वहाँ बारिश हो रही है.
It's pouring. Bombay was really bad. It took me 6 hours in the morning to go finish the meeting, drive back.
And Delhi तो खाली है. Roads are vacant.
But Delhi का तो पहले deluge हो चुका है ना?
नहीं, Biden is likely to arrive, or maybe he's arrived. The summit. The G20.
Oh yeah. Now तो Delhi is shining. G20. Participants कम दिख रहे हैं. 64. Normally there have been about 80, 90, 100, no? People are maybe still joining in.
Yes, ma'am.
The average attendance अभी is near about 100. Average I'm talking about.
Yeah.
Yes, sir. Usual is average about 100.
And total students that have enrolled for this webinars, the NEfPRO program is how many?
Jitendra would know better, but I think upward of 300. But many people watch it offline maybe
It's
afterwards because
around 450 last figure.
450. Yeah.
Now, I mean, there was a condition that you have to attend almost 80% of the webinars to be eligible, or it's what is based on?
They will get certificate only if they've got like 80% attendance.
Yeah.
80% attendance, which will be through the question answer session that you do.
Otherwise,
So we have an
also
attendance
eligible.
login. We have an attendance.
But many of the residents are like busy in duty, so they do see like videos later on, sir.
Okay.
Hmm.
Now, okay. And what is the result of the pre and post poll questionnaires? I mean, do you see a change happening? We always do that. You have done a questionnaire now, and then you'll be doing it again after the talk. How much is the change that you find?
So we have not calculated for this module. Like previous module is for around 30 to 35% on an average.
Increase in the score from the baseline.
Yes, sir. We'll be calculating the overall percentage, and for top 10 will award certificates. Like So it's already 10 minutes since we have opened the pre-test. So now we'll begin the with webinar. So thank you once again for joining us today. And today's webinar is on approach to antenatal hydronephrosis. And session again would be moderated by Madhuri Kanitkar ma'am and Pankaj Hari sir. So sir and ma'am, over to you.
So thank you, Jitendra, and a very good evening to all of you. We'll be moderating the session on antenatally diagnosed hydronephrosis. Among the series of webinars on CACUT that we have been having in the past few weeks, this is a very, very important topic because antenatal hydronephrosis is one of the commonest anomalies that is seen in the fetal ultrasound. While a large majority would be transient and would disappear, but the remaining would require some kind of a follow-up. And it's an important condition because it results in significant anxiety among the parents. And one would understand that a very small proportion of these patients will require surgical treatment and the rest all have to be managed medically. So for this, onwards now, to introduce the speakers, I will invite my co-chair, Dr. Madhuri Kanitkar, to go ahead with the webinar.
Thank you so much, Dr. Pankaj. And welcome to all the delegates who've joined in. I can see lots more have joined in. We've reached 73. And last week, we had the CACUT and presentation of large number of them were as antenatal hydronephrosis. So it's logical that we revise what we learned last time and take it forward. And we've got two excellent faculty to take this session. We have Dr. Shobha Sharma from the Department of Department of Pediatrics at the Safdarjung Hospital and Medical College, who will first cover an approach to the antenatal hydronephrosis, the clinical method. And thereafter, Dr. Subal Pradhan, who's Associate Professor of Pediatrics and Head of Division of Pediatric Nephrology at the Cuttack Medical College. He'll give us case scenarios, so we revise out all that's happened. With that, Dr. Shobha, can you please start your talk?
Thank you, ma'am. Thank you, organizers. And so I'll just share my screen. Is it visible?
Yeah, it's visible.
Thank you, ma'am. So, today's talk is about antenatal hydronephrosis and how do we go about it. So the learning objective from this talk should be the definition and extent of the problem, assessment of severity in both antenatal and postnatal period, how to manage and follow up these children both in the antenatal and postnatal period, then what are the indications of ultrasound and voiding cystourethropy and renal dynamic scan if we do it in the postnatal period. Then a little about fetal biochemistry, biomarkers, and role of antenatal surgery. And finally, about the role of antibiotic prophylaxis. So to have all this, we'll cover it under the following sections: introduction, severity classification, antenatal management, role of fetal urine biochemistry and biomarkers, postnatal management, and antibiotic prophylaxis and the incidence of UTI. And finally, instead of take-home message, I'll be summarizing the ISBN guidelines, which were the last proposed in 2013. So to start with, we know antenatal hydronephrosis is the dilatation of pelvic ileal system with or without distal urinary collecting system. And rightly so, it is the most common, as it was previously also described, most common type of the congenital anomaly of kidney and urinary tract, and it is seen in around 0.3 to 5% of pregnancies. And it is bilateral in about 50% of the cases, but the good news is that most of the cases they resolve with time in the postnatal or antenatal period, but a small number of them may require surgical intervention. And for these group of children is the main our concern, and whole of this management and follow depends so as to prevent the UTIs and urinary stone formation in these obstructive system. And also, if we just do not do anything, the ultimate result would be the renal dysfunction because of the obstructive uropathy or even reflux, which can cause UTI and later on scarring and the kidney damage. So our emphasis is to prevent all those things. So are we concerned about those physiological dilatation? No, but we are concerned about the other significant pathologies which can be associated with the antenatal hydronephrosis. And in 10 to 30% of the cases, it is pelvic-ureteric junction obstruction. Equal number of children may have associated vesico-ureteric reflux in them. Then we are also concerned mostly and very rightly so about the lower urinary tract obstruction, which in most common cause in males especially is the posterior urethral valve, and which is seen in about 1 to 5% cases of antenatal hydronephrosis. Then vesico-ureteric junction obstruction is another type of the obstruction which can be there and may present as antenatal hydronephrosis. Also, many times these antenatal hydronephrosis may be associated with the other chromosomal abnormalities, mainly the aneuploidies involving the chromosomal number 21, that is Down syndrome, and they may be associated with other renal congenital anomalies like MCTK as well. Now, how do we classify them? So classification can be based on, as I mentioned, that majority of these, they do resolve over time. So they may be, classified as a group of physiological dilatation of the urinary tract system. And then as opposed to the another group which do not show the resolution and which have significant pathological manifestations, like they may be obstructed system or sometimes non-obstructed system. So those are called pathological antenatal hydronephrosis. Then the classification can be based on whether there is a obstructive dilatation or there is a non-obstructive dilatation. Among the obstructive ones, the most important would be PUJ obstruction. Then others would be PUJ obstruction, ureterocele, and then of course in lower urinary tract obstruction group, PUV is most important. Then other less commonly present can be, but equally devastating, can be urethral atresia. Then they can be associated duplex system with ectopic ureteric insertion, which can also cause the antenatal hydronephrosis because of the obstruction. And in non-obstructive group, we may have the most common association is with VUR. Then other, it can be just non-refluxing megaureter, and then there can be a minor portion maybe because of the congenital condition of megacystis microcolon syndrome, and then can also be there in Croon Valley syndrome. But what we need to know more in the classification of this antenatal hydronephrosis is how do we classify and we go about the severity of these dilatation. So the three main classification which is being used most commonly, I will not say most commonly, but they have been in the evolving phase. So the most common one which is being used by the pediatric nephrologist overall is the anterior-posterior renal pelvic diameter grading system, and then is equally widely used, especially by the pediatric urologist, is the Society of Fetal Urology Association grading of the antenatal hydronephrosis. And the more recent one, which was given in 2014, is the urinary tract dilatation classification. Besides these three, we do have certain other classification system like radiological grading system, on-end grading system, just for tell about postgraduates about the existence of these system also, which are not much used, and more or less they are similar to the one which have been given above. Like radiological grading system, it is almost same as the SFU grading system, except that it has 5 grades instead of 4, which we'll be knowing just in a few slides. And they have graded accordingly, like presence of mild or severe parenchymal thinning. Similarly, on-end grading system also has a 4 grading system, and they have just differentiated between the medullary thinning and cortical thinning separately. In hydronephrosis severity scoring, they have just based on the renal dynamic scan and the ultrasound finding, just to predict the utility of surgery or predict the need for the surgery. And pyeloplasty prediction score similarly is based on the SFU and RPD system. So we'll be concentrating on the more widely used classification, and starting from that is the APD, or the anterior posterior renal pelvic diameter classification grading. Here it is done as we know that very clearly we can identify the complete renal architecture by second trimester. So so therefore the antenatal hydronephrosis is mostly diagnosed in the second trimester, and then of course in the third trimester, and the severity is based on the dilatation of the pelvis, and that also in the transverse plane. The kidney should be visualized in the transverse plane, and the prerequisite for this classification is that ideally the spine should be either in the 6 o'clock or 12 o'clock position, so that kidneys, they are in the both sides of the spine and in the transverse plane, and in that then we see the antero-posterior diameter, maximum diameter of the pelvis. So depending upon the size of this diameter, we do grade the hydronephrosis into 3 grades: mild, moderate, and severe, depending upon the size of this pelvis. That is, if it is 4 to we take in the second trimester, it is 4 to 7 mild, 7 to 10 is moderate, and more than 10 millimeter is taken to be a severe antenatal hydronephrosis. Similarly, if we see in the third trimester, the mild, moderate, severe varies starting from the 7 millimeter to 9 is the mild, and moderate is 9 to 15, and more than 15 is severe antenatal hydronephrosis. In any trimester, especially in the second trimester, it has been reported that if it is more than 10 millimeter, that means severe antenatal hydronephrosis is a very significant risk of presence of significant postnatal pathology in case of antenatal hydronephrosis. But there are certain caveats and disadvantages and limitations with this classification, although it appears to be a simplified one. First of all is that it has a great inter-operator disagreement rather, and agreement is seen only in about 60% of the cases. Then it depends upon the maternal hydration, it depends on the position in which you are doing the ultrasound, and then bladder filling, even the respiration also affects the pelvic diameter as well. So it may not be a very 100% accurate, and it may vary from person to person, the analysis. Then of course, as we are only concentrating on the pelvic diameter, there is no information about the renal parenchyma, ureters, bladder size, posterior urethra, and so on, which are, we know, are important in predicting the postnatal pathology. So an extension to that, the next system which is widely used, especially in the postnatal classification and grading of this antenatal hydronephrosis, was given in 1993 by the Society of Fetal Urology, and they have taken into account additionally, besides the renal pelvic diameter, which they have not measured by size, they have just concentrated on the dilatation or not dilatation of the renal pelvis, and there is no objective measurement of the renal pelvis here, but they have included both the central calyces as well as the peripheral calyceal dilatation, which seems to be important in predicting the postnatal pathology. And also they have taken into consideration the thinning and renal parenchymal thickness, or the thinning of the renal parenchyma, and accordingly they have divided the grade of this antenatal hydronephrosis in the postnatal period in 4 grades, starting from the normal examination, in which there is no ultrasound abnormality is detected, from the mild just splitting of the renal pelvis, which is seen in the grade 1. Then there is a central calyceal dilatation or few calyceal dilatation seen in the grade 2, which increases to overall uniform dilatation of all the calyces, that is both peripheral as well as the central calyceal dilatation, but it does not affect the renal parenchymal thickness. Whereas in the most severe group, that is SFU stage grade 4, the parenchymal thickness also reduces and there is a parenchymal thinning. So here the important thing is that they have included the major and minor calyceal system as well as the renal parenchymal thickness, which appears to be a important prognostic markers for deciding the postnatal pathology. And here the thickness, it depends. They have taken compared with the contralateral kidney, if it is less than 50%, and in case of bilateral, if the cortical thickness is less than 4 millimeter. So this is about the SFU grading. When it was compared both the grading system, it was seen that there is not much difference, and both the classifications, they can predict, and they can independently predict the presence of pathological hydronephrosis, with area under curve for SFU being 95%, whereas in case of RPD it is 91%. But it was seen that if both the systems are combined together, the sensitivity and diagnostic performance for the prediction of this postnatal pathology increases to 98%. So this is an important thing. But having said that, although this SFU grading has covered renal parenchymal thickness and calyceal dilatation, but there are certain other parameters in the ultrasound, like corticomedullary differentiation, cortical cyst, which comes under the appearance of the renal parenchyma, and presence of the ureteric dilatation, then presence of the bladder abnormality in the form of dilatation of the bladder or bladder wall thickness, and presence or absence of oligohydramnios, which is very, very important when we are considering a lower urinary tract obstruction, especially a very significant PUV. So those are neither the part of RPD or SFU classification. So most recent among that has come up the 8 societies, including the Society of Fetal Urology and American Society of Pediatric Nephrology, with many other societies. They came up with a unified grading system in which they clubbed the previous already widely used APD as well as the SFU system, and just to present a classification separately for the antenatal as well as the postnatal period. And here the antenatal, they have included, besides the RPD and the parenchymal thickness, they have included multiple other parameters, like they have included the appearance of the parenchyma, as I mentioned, that whether there is a altered CMD or presence of cortical cyst, or there is altered echogenicity. They have also included the abnormality, that is dilatation of the ureter, then bladder abnormality, which is seen in the form of if there is any ureterocele present, or there is thickness, increased thickness of bladder wall, or there is presence of dilated urethra. In all these things, it is taken as bladder abnormality and increases the grade of severity. And then they have also included the presence of oligohydramnios. This is besides taking the peripheral calyceal dilatation and APD diameter. So this is, they have given the 2 different classification for 2 different periods. Antenatal classification is denoted by the suffix A, that is UTDA, and postnatal classification is designated by suffix P, that is UTDP. Now they have also changed and redefined the term urinary. They have given the term urinary tract dilatation instead to be used instead of antenatal hydronephrosis. So they have given this classification. Now if we look into the antenatal period classification, they have grouped it into 2 main groups. One is the lower risk group and another is the increased risk group. So there are 2 groups. In the lower risk group, they have the entry point is of course the APD diameter, and if it is more than 4 millimeter in the second trimester, that is 16 to 27 weeks, or in the third trimester, that is more than 28 weeks, 2 time period have been taken. If it is more than 7 millimeter, this is taken as the entry point. So even if it is present with just central or no calyceal dilatation, it will be a lower risk group of the antenatal UTD classification, that is UTD A1. If there is any additional finding besides this, so if the accordingly, if there is RPD which is more than 7 millimeter in second trimester or more than 10 millimeter with any of the associated or independently, even if APD diameter is high, abnormal parenchymal thickness or appearance or ureter abnormality or unexplained oligohydramnios, it will automatically belong to increased risk group of the antenatal classification. Coming to the postnatal period, they have divided the this thing UTD, that is urinary tract dilatation, into 3 risk group: low risk, intermediate risk, and the high risk group. So again, here the entry criteria is the APD diameter at 48 hours postnatal life. So this is important here. So the APD diameter, which is measured after 48 hours of life, which is a mandatory to be done in all cases of antenatal hydronephrosis. So the findings at that time will decide the postnatal severity classification. So if there is a central, it is taken continue to can be as a lower risk group, whereas if there is any peripheral dilatation or ureter abnormality, it automatically goes to a intermediate risk group. And if addition to the peripheral calyceal dilatation or ureteric abnormality, if any other abnormality is there, even if there is no peripheral dilatation or ureteric abnormality, here it is very important that we should know that the findings which are there in the severe group, that is high risk group, if they are present in the absence of the intermediate or lower risk group, even then they will be classified as the high risk group. So if there is parenchymal abnormality or thinning of the parenchyma, or there is a bladder abnormality, it automatically goes to a high risk postnatal severity classification. I think I have made it clear. So this is how we, the UTT has come up with this classification, and main aim for proposing this classification was to give a unified and simplified, I will not say simplified, it is rather more complicated, because we are seeing multiple parameters here which may not be specifically important, specifically, I mean, easy to see in antenatal period, but just to make a uniform evaluation algorithm. So they have given this type of the classification. Now, how do we why we are giving so much, emphasizing so much on the severity of the antenatal hydronephrosis, how it impacts the postnatal outcome? So there are multiple studies regarding that. So I'll just, tell overall multiple studies, they have reported that there is a direct and linear relationship of the severity of antenatal hydronephrosis with the significant postnatal pathology, which is seen in overall around more than 30%, that is 36% of the cases. They have some or other type of the significant postnatal pathology, which needs careful evaluation and monitoring and even surgical intervention later on. And this increases with the severity of antenatal hydronephrosis, meaning that as the mild antenatal hydronephrosis will be associated with 12% risk of having significant postnatal pathology. If for moderate antenatal hydronephrosis, it increases to 45% and 88% if it is severe antenatal hydronephrosis. The exception here is VUR. So VUR is not defined by the severity of antenatal hydronephrosis because it is uniformly and equally distributed among all the severity of the antenatal hydronephrosis. Again, it means that the incidence of the VUR does not vary with the severity of antenatal hydronephrosis. Then this severity also decides the rate of resolution. So it can also give you an idea that how many percentage of these babies they are going to be resolute spontaneously or may have the physiological dilatation. So in mild cases, it will be 97% cases, they will resolve postnatally in variable period of time from 2 to 5 years of age, and 80% of the moderate, whereas only 20% of the severe antenatal hydronephrosis will completely resolve with time. So this is the percentage where we have to look carefully. And of course, if the antenatal hydronephrosis is observed in both second and third trimester, it is much more significant rather than compared to the percentage where we see only in second trimester, where the problem will only be postnatally in 11% of the patients. Now coming to the antenatal management. So antenatal management, actually it will again depend upon the severity of the antenatal hydronephrosis. So if it is a isolated second trimester antenatal hydronephrosis, mild, which is more than 4 millimeter, or third trimester more than 7 millimeter, in that case we have diagnosed it in the second trimester, so only one follow-up ultrasound in the third trimester is sufficient. Whereas, if we compare it with the UTD antenatal A1 group, so it is the low risk group. Again, they have suggested the same thing, that is additional ultrasound at more than 32 weeks. So we'll not concentrate here. Postnatal management and evaluation we'll see in the subsequent slides. So let us just concentrate on the antenatal evaluation of these children. Whereas in the high risk group, we have to do, UTT has also, the group has suggested more frequent follow-up every 4 to 6 weekly, and same is the guideline given by our Indian Society of Pediatric Nephrology, which says that if it is significant or moderate to severe antenatal hydronephrosis, follow-up should be done 4 to 6 weekly, except in some cases where we are suspecting lower urinary tract obstruction like PUV. So what are the markers or risk factors for PUV in the antenatal period? If we have oligohydramnios, if we have megacystis, I will just in the next slide share what is megacystis, that is enlargement of the bladder. If there is bilateral hydronephrosis, or there is presence of dilated urethra with keyhole sign. So any of these parameters, if it is present, it is highly suggestive of the lower urinary tract obstruction like PUV. And in these cases, irrespective of the RPD, the monitoring should be done even more frequently. And same is the guideline which has been given by ISPN 2013, that even more frequent fall monitoring should be done. Why it is done that? The rationale behind this is that in these cases, probably these are the cases which may go for, with one-to-one patient discussion, may require and may benefit from the antenatal fetal intervention like bladder decompression surgeries like vesico-amniotic shunt. And for this intervention, the ideal time is usually between 20 to 28 weeks. So if we do follow these patients very frequently, we'll be able to know, with the help of the favorable urinary biochemistry and favorable urinary ultrasound points, that if these patients will improve or will benefit from the antenatal surgery. So we do not want to miss on these cases, and therefore more frequent monitoring is required. Now, what do we mean by megacystis? Just a slide about that for postgraduates. Megacystis is a bladder enlargement in a very simplified manner, but the objective criteria has been given only for first trimester, and it is when the fetal longitudinal bladder diameter is more than or equal to 7 millimeter, and it is a very important risk factor for presence or suspicion of the lower urinary tract obstruction. So whenever we have this megacystis, we do have a suspicion of lower. That's why it is important to look for it. And if it is more than 15 millimeter, it is definitely highly suggestive of the lower urinary tract obstruction like PUV. Then if there are associated findings like there is increased nuchal translucency, umbilical cord cyst or extrarenal defect, it may point towards the associated chromosomal abnormality, as we mentioned previously, and there it is known as complex megacystis. There again we need to look for the other features as well. Whereas in second trimester there is no objective cutoff, just it is seen as megacystis is defined when there is failure to decrease in size after the during the 40 minutes time, probably the bladder will be decompressed spontaneously, and after that also if there is no decrease in size, probably the baby has megacystis. Now coming to the role of fetal urine biochemistry, what is its role and how do we do it? So it is a predictor of postnatal renal function, especially in cases of lower urinary tract obstruction. And most important role lies in not only predicting the postnatal pathology, but also it may guide for the requirement and benefit of the antenatal surgery. How do we do that? So fetal urinary sample is taken by a fetal vesicocentesis. It has to be done, of course, before 27 weeks and preferably between 20 and 27 weeks. And the various biochemical parameters which are or the analytes which are measured are the urinary sodium, chloride, calcium, osmolarity. We do have normative value for all of them, and if they are very high, then it may suggest there is a significant renal dysfunction. But again, single values do not mean anything. So in this case, we do the repetitive sampling. At least 2 should be done at a gap of 48 hours or after the bladder decompression, and we actually look for the decrease in the values of urinary sodium, chloride, calcium and osmolarity. you can just understand by this way that in case of AKI also, we do look for these urinary biochemistries, and the tubular dysfunction or renal dysfunction, or the intrinsic AKI, it is represented when there is a significant urinary sodium chloride, calcium, or calcium in the urine. So if there is high values of these analytes, it means there is a significant renal dysfunction, and failure to decrease in their levels even after the 48 hours of bladder decompression means that there is a probably irreversible renal damage has occurred, and probably these children will not improve with the antenatal fetal intervention. So this is how we utilize them. And as an extension to this, we do have certain new biomarkers, including beta-2 microglobulin and monocyte chemotactic peptide, transforming growth factor beta and angal, etc., which have been studied in multiple studies, and the studies are still ongoing, which may give you clue by their levels that probably there is significant renal dysfunction already existing or not. So this is how we do it. And again, recently there have been a lot of emphasis on the proteomic study. These urine proteomic analysis means that we do study fetal urine for the presence of very short chain proteins, which are known as peptides. And combination of these peptides or short chain proteins, they are used as a signature marker for the presence of significant renal dysfunction, or like in case of LU2O, that is lower urinary tract obstruction, if these are significantly high, they can predict the presence of early dysfunction or irreversible renal dysfunction below 2 years of age. So for PUV, we have this signature proteomic protein, which is PUV12, which can predict the presence of ESKD in cases of LU2O, that is lower urinary tract obstruction. And similarly, certain other metabolites can also be studied. So all these studies, they are still undergoing. We do not, as of now, have very confirmed validatory studies which can objectively and very 100% reliably tell that yes, if we do this, we can probably either we can go ahead with the surgery or antenatal surgery. More important than that these type of parameters, they are not available uniformly in all the centers. So because of all these factors, because of lack of availability, because of 100% reliability, and also presence of lot of validatory studies, these parameters, as of now, they are still, we can say, they are experimental, and they are not being used routinely for the management and follow-up of the antenatal hydronephrosis. Now, what are these fetal surgical intervention, and why do we do it, and who are the group who will require it? So again, this is if we say in mostly done in cases of lower urinary tract obstruction cases like PUVs or urethral atresia, and most common procedure which is utilized in the antenatal period is vesico-amniotic shunting. It is just the way of decompressing the bladder. So, and what will it do? It will improve the outcome of the renal function. Why? Because it will take away the pressure as the obstructive uropathy will be relieved, and the nephron loss will be reduced, and probably there will be improvement in the postnatal renal outcome. Simultaneously, as we are letting the amniotic fluid which is obstructed in the bladder into the amniotic fluid is increased, because amniotic compartment is increased because of the letting of this shunt, because of the presence of this shunt, there'll be increase in the amniotic fluid, which may improve again the lung development, and the perinatal mortality may also be reduced. So this is why this procedure is usually done in the antenatal period. And the other procedure as a definitive measure is the fulguration of the PUVs. It is done by laser method in the antenatal period. But having said that, if we see that these are an important and can be important way to improve the renal outcome, but most of the studies which are there, they are single studies, they are quite underpowered, and they do not show any clear outcome of these procedures. And also the recent meta-analysis which was done and published in 2018, although it showed definite improved perinatal survival, but it was only in the initial or short-term outcome was improved. Overall, long-term survival as well as the long-term postnatal kidney function was not affected despite these interventions. And also, we do not forget that all these procedures, they are very sophisticated, and you can say they need a very high level of equipment and expertise, and they are associated with high procedure related complication in so much so of about 40% of the cases, which include shunt dislocation, migration, and even fetal demise. So if we want to conclude on the need for antenatal intervention, we can just say that it can be offered to carefully selected cases where urine biochemistry before that also shows favorable outcome in the form of decrease in the analytes after doing the decompression, and also there are absence of the markers which shows irreversible renal dysfunction, like presence of renal cortical cyst or renal dysplasias on ultrasound. If it is there, and there is a discussion with the parents is done regarding the complications of these procedure, it can be offered to some patients, ideally at 20 to 27 weeks after discussion with the parents. Now coming to the babies who have antenatal hydronephrosis and born. So how do we go about evaluation and monitoring of these children, and why do we do it? So most important thing is that why do we do it? Aim is to identify those babies, because we know that about 70 to 80% they will improve with time, but we have also seen in the previous slides that a significant number of them will have significant postnatal pathology in the form of urinary lower urinary tract obstruction, or sometimes VUR, increased incidence of UTIs, and so our aim by doing the postnatal evaluation is to identify the neonates who will require surgery at the earliest, so that the renal dysfunction, the irreversible renal dysfunction, can be prevented and managed as soon as possible. But problem is that in the postnatal management and evaluation, lot of variability exists in the follow-up and in the indications and in the monitoring duration and frequency. So I'll be discussing them one by one, but I have tried to collate all the existing important guidelines, and will be present in the form of algorithm. Most importantly, the important thing is to know all the neonates who had history of antenatal hydronephrosis has to have postnatal monitoring. Even if there is improvement in the antenatal period, which has shown in the third trimester, there is no hydronephrosis, even then one postnatal ultrasound after preferably 48 to 72 hours has to be done. So why 48 hours to 72 hours? Because there is a period of physiological oliguria and dehydration in the initial 1 to 2 days, which may underestimate the severity of antenatal hydronephrosis. So it has to be done in all cases after 48 to 72 hours, except in cases of suspected lower urinary tract obstruction, where it needs to be done even more urgently within 24 to 48 hours. Now, let us proceed the postnatal management according to UTD classification and try to compare with the ISPN guideline. So in the postnatal management, here you see the classification. They have divided into low risk, intermediate, and high risk. So in the low risk, they have low risk will be those who have after 48 hours UTD or RPD of more than 10 but less than 15 millimeters, or may have some central calyceal dilatation. These babies, they just recommend to follow up ultrasound at 1 to 6 months of age, and VCUG and renal dynamic scan they have left to the discretion of the physician, and antibiotics again they have left to the discretion of the physician. Whereas in the P2, in which we have a peripheral calyceal dilatation and APD diameter is significantly more, that is more than 15 millimeters, or there may be ureteric abnormality, there more frequent ultrasound follow-up, that is 1 to 3 months duration is the time of second ultrasound, and again VCUG they have left at the discretion of the clinician, whereas antibiotic and renal scan also they have not recommended, they have just left to the discretion or one-to-one basis in the patient to be decided by the physician. However, in the most severe category, they have recommended same ultrasound to be done more frequently, with all the investigations to be done in all cases, with antibiotics to be started. Now, if we say in the form of algorithm, this may seem to be a little busy, but I would just try to take it. So let us see if the postnatal ultrasound is done at 48 to 72 hours, and they have divided with APD diameter more than 15 millimeter with the normal parenchyma, that is P2 classification. There they have suggested follow-up ultrasound, that is 1 to 3 months, and BCUG and RDS to the discretion of the physician. Here it is almost, we can say, similar to the ISPN, where actually they have suggested in all the moderate to severe hydronephrosis, which is SFU grade 3 and 4, that VCUG and RDS has to be done in all the cases. VCUG at 4 to 6 weeks, and RDS also. If VCUG does not show any VUR, then RDS is to be followed at 4 to 6 weeks of life. So it is slightly different than our ISPN guideline. Then if there is P3 classification, there the early ultrasound at 1 month is suggested, which is same as the guideline given by ISPN. And if there is no improvement, of course, they are undergoing the VCUG. And if there is no VUR, we have to do RDS scan, RDS renal dynamic scan. I will just discuss a slide about RDS and what is RDS and what is the importance of RDS. So in cases where there is VUR, we would like to see whether there is an obstructive system or what is the differential function. For that, we do the renal dynamic scan in those cases. And if there is VUR, we want to look for the scarring, and for that we do the DMSA scan, which is a static scan. So this is how it is almost similar to what we see in the ISPN guideline. Whereas again, the guidelines are similar if we are suspecting the lower urinary tract obstruction. So lower urinary tract obstruction, if there is bilateral hydronephrosis, if there is a hydroureter history of oligohydramnios or presence of dilated urethra, here we do the urgent postnatal scan within 24 to 48 hours, and depending upon the changes, we do early VCUG. In UTT, they have suggested to do within 1 week, and whereas ISPN suggests to do VCUG within 24 to 72 hours. So otherwise it is same. And then depending upon the findings of VCUG, if it is PUV, it has to be done urgent surgery. If it is VUR, again looking for the scarring, we do DMSA. And if it is no VUR, but still it is showing LU2O, we do go for the RDS scan to look for the obstructive pathology. So this is how we do. In other cases, we just do with the, depending upon the finding which we get on the ultrasound. So if the finding is in P1, that is, there is in ISPN, it will be moderate, that is SFU grade 3, whereas in UTD classification, it will come as P1. Again, it's the same, 1 to 6 months we do ultrasound, and if it is a worsening, then we do VCUG or RDS. If there, it is almost similar to what we do in ISPN, but in case of UTD, they have left it to the discretion of the physician. Whereas in UTD P1, RDS is not recommended at all by the UTD group. Coming to the mild hydronephrosis group, how do we do it? So here the ultrasound, only one follow-up ultrasound, one we have done at 48 hours, and after that we follow up with another ultrasound, which can be done anywhere between 3 to 6 months, and we just follow these cases up with the ultrasound only. Here the chances of resolution are much more high, and chances of VUR is low. So just follow up ultrasound, and again the frequency and duration of ultrasound is not unified. There is no consensus for that, but we do follow initially 3 monthly and then 6 monthly and then yearly ultrasound till there is resolution of the antenatal hydronephrosis. In these cases, the risk of UTI is also low. Whereas if there is normal postnatal ultrasound in the 48 hours, still we do a repeat ultrasound at 4 to 6 weeks. You can ask this question, why we are doing in a normal cases. This is because a very few percentage, around 10% to 11% of them may have second ultrasound, which may show, which was not showing earlier, hydronephrosis. So to identify these cases and to not miss these cases, sometimes there is even recurrence of the hydronephrosis after resolution, especially in the cases who had antenatal hydronephrosis. So a repeat ultrasound, even if the first ultrasound is normal, is warranted in all the cases. So coming to the investigations, what do we do and what do we look for in postnatal ultrasound? Besides RPD, we should look for renal parenchymal thickness and renal parenchymal appearance. In appearance, we do look for the echogenicity, the corticomedullary differentiation, presence of renal cortical cyst, presence of ureteric dilatation if it is more than or less than 4 millimeter, bladder changes, whether there is any thickness or bladder length change or increase or decrease in the volume, dilated posterior urethra, and also other congenital anomalies. So these are the findings which are and which should be additionally looked in the postnatal ultrasound besides the RPD. Now, what are the poor prognostic markers for the significant pathology? So in multiple slides, we have already discussed that presence of increased cortical echogenicity, thinning of parenchyma, presence of overt renal dysplasias, presence of oligohydramnios, presence of dilated bladder or the increased size of the bladder or increased wall thickness. These are all poor prognostic marker for the postnatal kidney function. Coming to a slide about renal dynamic scan. So I was discussing in multiple slides previously that we have to do renal dynamic scan in all those cases where we have done VCUG and there is no VUR. So what is the importance of doing the renal dynamic scan? Here we are just, want to estimate the differential renal function, and it can also differentiate between the obstructive and non-obstructive hydronephrosis. So here, if I just want to emphasize the right upper side of the panel, you can see the radio tracer, it is injected. And after that, there is uptake of the radio tracer by the kidneys within 2 minutes of injection. And within 10 minutes, there is 50% of the radio tracer should leave the kidney and leave the system. So this is represented in the form of time activity curve, which we called as the renogram curves, which you see on the right upper side. These are the normal renogram curves, which is represented by red and blue lines. So you see immediate peak in the curve, which is shown by the immediate increased uptake. And then there is rapid decline of the renogram curve, which shows the decrease or clearance of this radio tracer from the collecting system. So this is why it is known as the dynamic scan, because here not only we see the function of the kidneys by the glomerular filtration, we are also seeing the clearance of the radio tracer from the collecting system, and which should not take more than 10 minutes. So if it is more than T-half, that is more than T-half or 50% of the radio tracer is still there in the collecting system for more than 20 minutes, or differential renal function is less than 40%, it is an indication for pyeloplasty. If we have done a repeat scan at 3 to 6 months and there is decrease in the differential function by more than 10%, even then it is suggestive of the obstructed system and suggests the benefit of the pyeloplasty. Ideally, it should be done at 4 to 6 weeks of life, and the most commonly used radioisotope is the DTPA, because we do not have the radio tracer of the choice, that is MAG3. It is not easily available, although it is the most ideal one, because it not only tells you about the anatomical delineation and glomerular filtration, that is function, but also very accurately it tells about the cortical clearance, collecting system clearance or the obstruction in the system. So short of that, we are using either DTPA. So as DTPA is not much useful in immature kidney, so we also use the EC scan. For the scar specifically, we do the DMSA scan, which is the renal static scan, to see for the scarring, because it is mostly taken up by the proximal tubules and it is extraction is very low. So we can see the outline and anatomy of the kidney well identified. Obstructive pattern, as I have already said, it is in the lower right panel. You can see it is an obstructive pattern in which there's a plateau-like curve you can see in one of the left side of the kidney. If you can see the left side of the tracer, it is taken up by the kidney, but it is not left the pelvic system. So there is a significant PUJ obstruction. Because of that, there is pelvic collection of the radio tracer is still there, showing, and it is represented in the form of the plateau type of the RDS or the renogram curve, and it shows the obstructed system. Just a slide about antibiotic prophylaxis. Most of the previous studies have shown that there is significant risk of UTI in the obstructed hydronephrosis, and there's a linear relationship between the degree of UTD and developing UTI. And therefore, many authors, they do, and even ISPN 2013 guidelines, they have suggested using antibiotic prophylaxis in SFU grade 3 and 4 pending the investigation and identification of UR. But the recent studies, they have not found any association of this UTI with the antenatal hydronephrosis, and the meta-analysis which has been done, they have not also proven the benefit of these antibiotic prophylaxis, that they can surely prevent the UTIs. Therefore, there is lack of uniform consensus of use, although still many of the groups, they are still recommending and suggesting the use of antibiotic prophylaxis, especially for the SFU grade 3 and 4. But the newer ISPN guideline, which will be out soon, probably in the end of this year, they have suggested against the use of antibiotic prophylaxis in just SFU 3 and 4, and they have just suggested that it should only be used in case if there is a high grade UR is there, that is grade 3 to 5. So instead of take home message, I'm just summarizing. Probably this is just the recapitulation of what we saw in previous slides, that we have to do the RPD system for the antenatal, can be used SFU system, whatever, especially for the postnatal period. Additional parameters which we should look for in ultrasound, I have already discussed. Then how do we go about the antenatal monitoring? MTP, here I want to highlight, it is never an indication just for the presence of antenatal hydronephrosis, but it is only suggested when there is other life-threatening extrarenal abnormalities are there. Otherwise, just for antenatal hydronephrosis, however severe, it is not indicated. Then more or less it is same. Thank you.
Thank you so much, Dr. Shobha. Can you stop sharing the screen? Thank
Yes.
you.
Yes, ma'am.
I think it was an excellent, very comprehensive, very detailed analysis, and especially since our last guideline is of 2013, you've really brought out the newer things which have changed, and nicely summarized that we are changing these with the new UTI guidelines. So that I think, and especially with the classification having come after that in 2014, but with a little more conservative as everything is going. And there are some questions which we can take in the end, especially that question more about vesicoamniotic shunt. If there are small single questions, you may answer it, but I thought we will take it as a discussion because everyone would like to hear you. So without this thing, we'll first go to the next talk so that it will help everyone crystallize. You know, it's a long topic and it's been this thing. So Dr. Subal, can you show us some case-based discussions?
Thank you, Mom. I'll be re-emphasizing what has been discussed by Dr. Subha through case-based approach. So this is the first case scenario. Typically, parents come with a fetal scan report. This is the fetal scan of 26-year-old mother, second pregnancy, which reads as cephalic presentation is fetal heart at 145 beats per minute, placental is posterior, Leaker volume was adequate with AFI of 12.6 centimeter. There is moderate pelvic dilation, which is seen in the left kidney, with epididymal left internal diameter was 30 millimeters. Fetal movements, weight was normal, and the gestation was 28 weeks, both by ultrasonography and as well as LMP calculations. So what is wrong in this scan? So there was dilatation left pelvis. So it is still debatable what should the normal renal pelvic diameters in fetus. So quickly summarizing, this is a table showing the normal value of contact dilatations. For the postgraduate, please do remember that if the apical diameter is less than 4 meters by 16 to 27 weeks, or less than 7 meters by 28 weeks, or less than 10 meters by 48 weeks, considered normal and not too dilated. So 4, 7, 10 is the cutoff point. We said there should not be calcial dilatations, both central and peripheral. The renal parenchyma should be normal. The ureter bladder should be normal, and there should not be any online oligohydramnios. So in normal fetal kidney should have normal echogenicity, no hydronephrosis, visual bladder, ureter should be normal, and the normal amniotic fluid index AFI, as defined by Morin et al. Based on the different gestational age in the normal pregnancy. So what should be our goal for evaluation? So coming back to the case scenario, so this child had fetus has As per the SFU grading system, there is moderate left renal pelvic hydronephrosis. So what should be our goal for evaluations? So antenatally should look for the severity and degree of hydronephrosis. Also look for the associated major congenital endpoints. Postnatally, you need to look for the to identify the underlying etiology, to assess the risk of immediate or future renal damages, to assess the risk of urinary infections, though is not common in antenatal hydronephrosis postnatally. Also, functional significance of an apparent obstructions and need for surgical corrections. So overall, again, re-emphasize that we need to look for whether the fetal hydronephrosis chance of spontaneous resolutions versus clinically significant risks of CACO in future. So what are the tools you need to evaluate for the antenatal hydronephrosis? Ultrasonography is used for both antenatal and postnatal evaluations, as it has been mentioned in several guidelines. Antenatally, to look for the degree and severity of hydronephrosis, as well as the laterality, whether it is bilateral. Postnatally, at least should be performed up to 40 hours. The reason has been already mentioned by Dr. Silva. However, in situations like suspected low obstructions like Western Hall or Poon belly syndrome, or if there is presence of bilateral hydronephrosis or hydronephrosis, or presence of solitary kidney with epidiameter more than 15 or SFE grade 2, should be done within 48 hours. For the MCUG recommended in suspected fewer, ideally performed at 4 to 6 weeks. However, in suspected low obstructions or suspected PUV, it should be done within 48 hours. DTPA role has been already highlighted. MAC3 or LSS can be done at 1 to 6 weeks. However, if you're performing DTPA, should be delayed up to 6 months of age. So there have been mentioned in different guidelines. However, MRI has been now fetal MRI has been now increasingly used by many centers because of excellent delineation and number of structures. And if you are using fetal MRI, it should be done around 30 weeks of gestations. So as I have said, the USG is the most common tool for antenatal as well as postnatal evaluations. So besides the degree of hydronephrosis, we need to look for the calcium dilatation, both central and peripheral dilatation, renal parenchymal thinning, renal parenchymal abnormalities, aortic dilatation, including presence of erythrocytes, any bladder abnormalities, presence of oligohydramnios, or presence of any external major congenital anomalies. So usually should be done after 20 weeks of gestation, because before 20 weeks fail to detect major congenital anomalies. So this is a time around 18 to 20 weeks is the ideal time for renal anomaly scan. So how when to do the ultrasonography? Again, this is controversial and debatable. The different system has different recommendations. The RPT system recommend if there is mild and unilateral hydronephrosis, should be repeated during third trimester. If there is mild or bilateral hydronephrosis, should be repeated every 2 to 3 weeks. If the RPT dimension is more than 10 millimeter in third trimester, you should start with prophylaxis and this should be opted. While the SFU system has similar recommendations, utility system has been already discussed by Dr. Sobha. If there is low risk in A1, should be performed in third trimester. In A2 to 3, if the increased risk, it should be done every 4 to 6 weeks. In P1, postnatally, if there is low risk, should be obtained ultrasonography within 1 to 6 months. While in the intermediate risk group, it should be done within 1 to 3 months. In high risk group, should be done within 1 month. In addition, where the low risk and intermediate risk in P1 and P2 group, PCOG and antibody prophylaxis depends on the physician discretions, whereas in P3, in high risk group, both MCU as well as antibody prophylaxis is recommended. So I explain also similar recommendations. If there is unilateral hydronephrosis, you need to repeat ultrasound during third trimester. If there is bilateral severe hydronephrosis, the serial ultrasound should be done every 2 to 6 weeks, whereas if associated system malformations or a presence of additional subsign should be referred to a specialized center. So again, how often you should do the ultrasonography? There is no consensus or agreed upon protocols. So ideally, first ultrasound should be done around 20 weeks of pregnancy, and the repeat scan should be done at 28 to 32 weeks during third trimesters. However, we need to frequent ultrasonography monitoring in presence of bilateral hydronephrosis or PUV, suspected bladder outlet obstructions like Poon belly syndrome, or presence of severe hydronephrosis in solitary kidney. So etiology already been highlighted by Dr. Sobha. So overall, there are 3 categories: if you look at the causes of antenatal hydronephrosis, major of the cases are transient, around 50 to 70% cases, and they are benign, doesn't require any interventions. The causes could be transient narrowing of the PUJ junctions, or delayed retrograde peristalsis in the pelvic musculature. But 10 to 40% attributed to viewer, that could be primary or secondary, but 10 to 30%, around one-third of cases, could be obstructive causes like PUV, PUJ obstructions, erythrocytes, or ectopic ureter. So here's the group that need to be identified early and that need to be referred to the surgeon for early intervention to prevent further progression of kidney disease. So coming back to the case scenario, so the pregnancy was allowed and term female fetus is born with normal birth weight with upward score of 9 and 10 at 1 and 5 minutes. So we repeat ultrasonography at day 7 of postnatal life, and that show persistent hydronephrosis with APD diameter of 17.7 millimeter left kidney and ETD P2 with intermediate risks. So again, we repeat at ultrasound at 1 month, and that show consistent hydronephrosis with diameter 18 millimeter. So we did a VCG that shows no viewer. So again, move to lot of obstructions, and we did a DTP scan, and you can see in the DTP scan the renograms. The red green dotted line represent the left kidney, and the violet line represent the right kidney, and there is upward trend of the right kidney, left kidney, showing the significant obstructions. This also reflected in the delayed image of the DTP scan. There is significant retention of pressures, with the differential function of the left kidney 34% and the right kidney 56%. So this is a case of significant obstruction, PUJ obstructions. So not all cases of PUJ obstruction require surgical interventions. The indications of surgery are if the differential function less than 40%, or if there is decline in function more than 10% on follow. So this is a case where you can see the left kidney function is 34% and requires surgery, and the patient was done pyeloplasty. So quickly moving to the next case scenario. This is the fetal scan of a 24-year-old mother. Had cephalic presentations, placenta was anterior, lacar volume was adequate with AFI of 17.8 centimeter. There was moderate pelvic dilatation in both kidneys. The APT diameter of the right kidney was 20 millimeters with ETD A2-3, while the APT left renal diameter was 40 millimeter with ETD of A2-3. Fetal weight is however normal, and there are no gross congenital anomalies seen at presence with gestational age of 37 weeks, almost third trimester. So as far as the RPD classifications fall into the category of severe hydronephrosis. So these report typically come parents with anxiety, and this is a headache for both parents as well as physicians. So what are the prognostic indicators for bilateral fetal hydronephrosis? So again, the process depends on the severity of hydronephrosis, laterality, whether it is unilateral or bilateral, any renal parameter changes like echogenicity, loss of CMD, or presence of cortical cyst, presence of erotic dilatations, or abnormalities of bladder size, thickness, or empty, or the presence of concomitant oligohydramnios. So is there any role of fetal interventions? Again, this has been limited to low intent obstructions, particularly posterior valve, because for the resident, fetal intent obstructions can lead to oligohydramnios, leading to renal dysplasia and pulmonary hyperplasia. And this is the independent risk factors for neonatal morbidity and mortality. Indications of fetal intervention include significant renal oligohydramnios, suspected good renal functions, or absence of other life-threatening anomalies. Various procedures performed in different centers include open fetal surgery, vesicometroscopy, vesicocentesis, renal pelvic aspirations, or fetoscopic fluoridation of the posterior valve. So what are the unfavorable prognostic factors? If there is history of prolonged oligohydramnios or presence of renal cortical cyst, fetal urine content of the sodium more than 100 milliliters, chloride more than 90 milliliters, or osmolality more than 201 millimole, or if there is elevated beta-2 microglobulin, or there is presence of reduced lung volume. There are several studies have looked at the outcome of maternal diagnosis of UTD based on the renal perimeter diameters as well as the degree of enteral hydronephrosis. If the diameter is more than 20 millimeter, 94% requires surgery or long-term follow-up. If the diameter is 10 to 15 millimeter, around 50% requires surgery. After less than 10 millimeter, require only 3% surgical interventions. While the mild hydronephrosis between 5 to 9 millimeter, most likely fewer, where the severe hydronephrosis from 10 to 15 meter, most likely UJ obstructions. So what does it mean? The more severe the hydronephrosis, more likely they require surgical interventions or long-term follow-up. However, the exception that has been already discussed by Dr. Soba, though risk is predictable with severity of hydronephrosis, however, in viewer which cannot be predicted from the degree of uterine dilatations. And this is recently published a review article a couple of months ago, looking at the long-term outcome of antennal detected uterine dilatations. And this paper shows that in long-term follow-up, permanent kidney damage is diagnosed approximately 40% children with moderate to severe uterine dilatations. However, the hypertension, proteinuria, and PCF moderate only 0 to 5% cases. Overall, the mild EPD, the long-term outcome is excellent, and these children should not be subjected to unnecessary examinations and follow-up. So can we conclude that around 1/3 of fetal hydronephrosis resolve before birth, another 1/3 resolves spontaneously within first 2 to 3 years, and the remaining third will end up with CACO, requiring long-term follow-up and surgical intervention. So coming back towards a scenario, this is a 24-year-old mother had bilateral severe hydronephrosis with no cross control anomaly. So pregnancy is allowed, and the main unit born at 30 weeks with normal bowel fluid. So how will you evaluate this child? What will do next? So let's look at the ISPN guideline. So first scan should be done within first weeks, and even if the first scan is normal, the repeats can be done at 4 to 6 weeks. If there is no hydronephrosis, no intervention required. If there is mild hydronephrosis or SP grade 1 to 2 or epidiameter 7 to 10 millimeter, ultrasound should be done every 3 to 6 months until resolution of hydronephrosis. If there is moderate to severe hydronephrosis or mild hydronephrosis with ureteric dilatation, that means mild hydroureteronephrosis, MCG should be done. If there is no viewer, you need to do DTPA to obstructions. If there is no obstruction, again need to follow up every 3 to 6 months until resolutions of the hydronephrosis. If there is obstruction, again the indication surgery already I have mentioned. If the difference is less than 40% or decline in functional more than 10%, need surgical interventions. If there is viewer, when you consider antibiotic. If there is low-order obstructions, may need surgical interventions. Regarding antibiotic prophylaxis, again this is a debatable area. And this is a meta-analysis by Dr. Capluccio et al. From Montreal, Canada. And though it favors high-grade hydronephrosis, still it is debatable, cannot be routinely recommended to all children with UTD. So again, coming back to our case scenario. So we did ultrasonography because we had bilateral severe hydronephrosis, and that is consistent with bilateral severe hydronephrosis with epidiameter 17.7 millimeter left kidney, the right kidney, and the 14 millimeter left kidney with bilateral hydroureteronephrosis with thickening of the bladder wall. So straight away we go for the VCOG, and that shows bilateral grade 5 viewer with posterior hall. You can see in the image. So this child was subject to surgery with all fulgurations and put on antibiotic prophylaxis, and this child need long-term follow-up to monitor the renal functions because they are having risks of chronic kidney disease, hypertension, proteinuria. So quickly conclude my talk. ANH remains a clinically challenging diagnosis for both physicians as well as surgeons, and the risk prediction for CACUD is quite challenging based on the current classifications. The all infant detected to have ANH should be evaluated postnatally by ultrasonography. Other imaging include VCOG, MACT, or DTPA. Fetal intervention should be done in selective cases of ANH in specialized centers. Postnatal follow-up ANH is a dynamic process, and the outcome depends on the underlying etiology. Long-term outcome with mild ANH is excellent, should not be subject to unnecessary examinations and follow-up. However, still none of the classifications has 100% precision in predicting the risks of surgical interventions. So we need a better classifications, also evidence-based intervention in those children for long-term follow-up and monitoring. So thank you all the chairpersons. Over to you for further comments and questions.
Thank you, Dr. Subal, for highlighting some of the important aspects through your cases. Dr. Pankaj, would you like to lead the questions? There are three in the chat box.
Yeah, there are three. Thank you, Dr. Madhuri. There are three questions which we decided that we should take it
Stop
live.
sharing your screen.
Yes, I'm doing that.
So, Dr. Shobha, can you tell us, as this person is asking, the attendee is asking, a little bit more about the vesico-amniotic shunt, about what is it?
Yeah, so vesicoamniotic shunt, as the name is suggesting, we are making a shunt between the fetal bladder and the amniotic fluid compartment of the mother's womb. So here it is actually needed in cases of severe lower urinary tract obstruction. We are suspecting, and we have got features like severe oligohydramnios, or there is a bladder changes. So when we are suspecting that in the antenatal period, and by the ultrasound which we have done in around 20 weeks, in that case, these children, just to prevent, because what will happen if there is a less oligohydramnios, it will also affect the development of the lungs and will impact the immediate perinatal outcome of the child. Moreover, because there is a continuous pressure, uropathy, or pressure on the nephrons, it will cause the progressive loss of the nephron, and that is known as the obstructive uropathy, and will lead to the irreversible kidney damage. So if we are very sure that the baby has this features, clear cut suggestive of PUV or lower urinary tract obstruction with oligohydramnios, we try to decompress the bladder antenatally by using this procedure, which is known as vesicoamniotic shunt. Is a kind of shunt is or a, you can say, a way bypass is made. So if there is a PUV, suppose, so the terminal path is blocked. So what we do, the proximal end, that is the bladder of the fetus, is connected with the amniotic fluid, so that continuous urine which is made by the fetal kidneys goes and forms and continues to make the amniotic fluid. So it improves, and that the lung development also improves, and also the pressure on the kidneys is kidneys, they get decongested. So it helps in the overall outcome of the baby, especially in the immediate perinatal period.
Okay. In the continuation of the same question, the person is asking us to how, please explain the interpretation of fetal urine biomarkers. So, Shobha, would you just add to the fetal urine biomarkers?
Yes.
Yeah. So because again, when we are talking about these things, trials have shown that these are not very useful in terms of long-term benefits to the kidney. As you Dr. Shobha, you had already shown that 6 months the survival does improve in the meta-analysis, but then overall outcome in terms of ESKD later on is not changed by any of these interventions. However, you could still talk about the fetal urine biomarkers.
So again, I would not say that because of the same reason, because the reliability has not been found 100%, and they are not been found that it very specifically can predict the overall outcome, especially in the long-term cases. So urinary biochemistry, again, if we want to understand it in a very simplified manner, we are just measuring the analytes in the fetal urine. So these analytes, they are essentially those electrolytes like sodium, calcium, chloride, and we see the urinary osmolality. And then there's very important and studies about beta-2 microglobulin, which are done, but at a very specialized center. They are sometimes they are done case-to-case basis, where the facilities they exist, where most of the studies which they have found that if suppose you have taken the fetal urine and by the vesicocentesis from the fetal bladder, and you have analyzed these analytes, as the Dr. Subal has given the normative value, that it should be less than, sodium should be less than, urinary sodium should be less than 100 millicoulant per liter, calcium should be less than 8, and beta-2 microglobulin should be less than 4 milligram per deciliter or per liter. So if this are there, that means the kidney function is intact. So if the analytes, they are very high in the fetal urine, but after 48 hours of decompression of the bladder, these analytes again, they come down. This shows that there is chance that this kidney will improve or benefit by the decompression procedures like vesicoamniotic shunt and sometimes PUV fulguration, etc. It does mean
yeah, absolutely right. But I'd like to add also, because firstly, it's an invasive this
yes,
thing.
and very high complication. Yeah.
And what if this thing also, it's the measurement over time, serial. So, and how it changes, or how after decompression. Now, how many centers really are able to do that? So, I think advising fetal urine without having all the interpretations, being able to do it serially, being able to look at, post decompression values, I think at this stage we should not recommend this as a process.
Right,
Okay, then,
absolutely right. Yes.
so there's a question that Subal, you could answer that how can one differentiate VUR related scarring versus the primary dysplasia on the DMSS scan?
So, I could not read the questions. Primary viewer.
Yeah.
How could you differentiate between the VUR related scarring versus the primary dysplasia on a DMSS scan? Now, when he means VUR related scarring, I understand that the person means scarring secondary to urinary tract infection. Did you get the question, Dr. Subal?
Yes, yes, sir. Yes, sir.
Yeah. Or yeah. So.
No, you don't need to look at this thing if you're searching for it, Subal. I think basically they just wanted to look at the type of. I mean, a practical thing like we see the ones which are after UTI tend to be more wedge shaped, tend to be more like a moth-eaten kidney, whereas a VUR kidney, which is a dysplastic kidney, is a more uniform, a much more smoother outline, smaller in size. So these are the grossly. Anything more anyone wants to
yeah,
add?
I would say very clearly two are very different. The dysplastic kidney that is seen associated with severe forms of VUR is typically small, shrunken in size, more often seen with high-grade VUR, often seen in boys. And this is generally, understand that it's not amenable to any treatment. On the other hand, UTI-related scarring, which has been now, we know there are multiple randomized controlled trials that have been published, and they figured out the scars on the DMSS scan. They used to be smaller scars. They can be multiple, but they are distinct photopenic areas. And in terms of the long-term outcomes, these kind of scarring is typically seen in girls with recurrent UTIs in the history. And this is generally associated with some hypertension, but the incidence of hypertension and end-stage kidney disease is very low in this kind of a category as opposed to the dysplasia congenital.
Yes, sir. Yes, rightly, sir. And these dysplasia, if you're talking about on DMSA, as sir and ma'am said, it is completely normal that there'll be uniform decrease and there'll be uniform decrease in the uptake of the radio tracer. So that is what we see in the dysplasias, and that will be visible, I think, on the ultrasound also. You'll see cortical cyst, CMD will be altered, and there will be diffuse increase in the echogenicity, which is seen in the dysplasias, and uniform decrease in the corticotracer uptake. Whereas in scar, as both of them have mentioned, it will be a wedge shaped or there'll be irregular, photopenic areas. I think. So
and also SR told, no, more like in the high grade of VUR, as with the high grade of VUR, unlike in renal dysplasia, congenital renal dysplasia usually have low grade of VUR.
Okay, so Dr. Madhuri, with your permission, it's already, I think the session has gone on for a little long. Can we stop here and ask Jitendra to
Run the post test.
Run the post test.
Yes. Thank you so much again from Dr. Pankaj and me to the speakers for a lot of work done, lot of review of literature, and I'm sure the attendees would want your presentations to get time to assimilate so much of knowledge that has been shared today.
Thank you, ma'am. Thank you, sir.
Thank you, Subal. Okay, Jitendra, over to you.
Thank you, sir and ma'am. And thank you, Dr. Shobha, Dr. Subal, for this night interactive presentation. Sneha, can you begin with the post test, please?
Yes, sir. So I'm launching the first poll. Is it visible?
Yeah.
Okay. "15 seconds more." "30 seconds. Thank you. Moving to the next question. 10 seconds. 20 seconds. 30 seconds. Thank you. Moving to the next question. Twenty seconds more. 10 seconds more. 30 seconds. Thank you. Moving to the next question. Fifteen seconds. 'Thank you. Moving to the next question. Ten seconds. 20 seconds. 'Thank you. Moving to the next question. Another 20 seconds. Last 5 seconds. Thank you. Moving to the next question. Fifteen seconds gone. Thank you. Moving to the next question. Ten seconds gone. 20 seconds gone. 'Thank you. Moving to the next question. Another 15 seconds. Thank you. Moving to the next question and the last question. Last 10 seconds. Thank you. Thank you so much. Thank you, sir.
Thank you, Sneha. We are done with poll, right? So thank you everyone once again for joining us. With that, we'll close the today's session. We'll hope to meet you next Friday again.
Thank you so much, everyone. Thank you for joining with us. Thank you.
Thank you.
So, with all of your permission, we are signing off this session here. Good night.